Welcome, everybody, to our 30-minute program, Patient Perspectives on Residual Symptoms with Major Depressive Disorder with a focus on insomnia. I'm Dr. Leslie Citrome, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York, and I'll be serving as your moderator today. Joining me are three faculty members, a family practice physician, a psychiatrist, and a patient advocate. Welcome Dr. Paul Dalgramji, who's family physician at Collegeville Family Practice and medical director of health services at Ursinus College in Collegeville, Pennsylvania. And welcome Dr. Michael Thase, professor of psychiatry at the University of Pennsylvania, Perelman School of Medicine in Philadelphia, Pennsylvania. Welcome aboard, and a special welcome to Natalie Smith, patient advocate from Philadelphia, Pennsylvania. We're going to focus today on a patient's perspective related to residual symptoms of depression. And this is pretty interesting because we don't often do this. We kind of focus on the symptoms in terms of an interview in the PHQ-9, and we need more context here. So to get us started, Natalie, can you give us a brief overview of your journey with depression and what medications have you tried?
Sure. I think I first experienced what I now know to be symptoms of anxiety and depression in middle school. I did not start counseling until my mid-20s, which lasted for a couple of years, but then I moved states and lost access to care. My interpersonal relationships and career, I work in animal sheltering and veterinary medicine, seem to exacerbate my depression quite a bit. And my insomnia started in my mid to late 20s, and it comes and goes very much connected to my level of depression. So I first started SSRIs in my mid-20s and was also prescribed a benzo for acute anxiety episodes at the time. And after a year of trying a couple different SSRIs, I stopped them since they did not seem to be very effective. And the side effects were really challenging, specifically like nausea and GI upset. I have continued to use the benzo, sometimes unprescribed, sometimes prescribed, as needed on and off since then. Almost 3 years ago, I tried infusion therapy of a dissociative anesthetic and had very severe nausea and GI side effects. After many treatments, the side effects did lessen, and the people closest to me felt that it did seem to help me. The treatment did seem to help my depression. Last spring, I tried guided therapy with the same dissociative anesthetic, but as an IM injection, but the side effects were so intense that I didn't go more than once. And I've since trialed more SSRIs with GI and nausea side effects, as well as a tetracyclic antidepressant without any success. So I use over-the-counter gummies, acupressure, and lifestyle changes to manage my insomnia.
Well, thank you for that. It seems to be pretty complex here with partial response and side effects and trying various things. And the bottom line here is that not all symptoms are actually addressed with our treatments all the time. And sometimes it's pretty challenging to find something that will be well tolerated for that individual person. Thank you for sharing that with us. Michael, can you give us a brief overview of what we mean by residual symptoms in major depressive disorder?
Well, when people receive a treatment for depression, there are three things that can happen. They can just not benefit at all, including having intolerable side effects, making the treatment not practicable. Or the treatment can help a lot, and you get a really quality level of improvement back to your best self, or an intermediate effect in which the treatment has some benefit, but some number of the symptoms that persist, and continue to get in the way of the person's life. And we would call that an incomplete remission or response with significant residual symptoms. But in fact, even among the subset of people who have a really high quality level of benefit, there could still be one or two, sometimes even three minor persisting symptoms. And over the last 20 years, there have been a few surveys evaluating people who have responded to antidepressants, but then looking at their burden of residual symptoms. And across surveys, over and over and over again, the most common residual symptoms of a treated depression are some persistent sleep difficulty, more often insomnia than hypersomnia. That's one. Two, being daytime fatigue, and three, being impairment in concentration and other kinds of higher level cognitive processing. And we know from other surveys doing longitudinal follow-up that if you have one or more of these clusters of residual symptoms, you are less likely to have a full recovery of quality of life back to your best self. You are more likely to have greater risk of relapse and recurrence and subsequent development of chronic depression. And unfortunately, some of the longer term risk associated with depression, including adverse effects on health and longevity, can continue to haunt you. So that incomplete benefit or benefit with residual symptoms really remains a very important target. We think that you need to have a full remission, truly back to your best self, in order to have the best mitigation or the best way of dealing with the long-term consequences of depression.
Yeah, very important point. We tend to focus on a patient's depressed mood, their lack of enjoyment of activities they used to enjoy, and being able to interact with others and so on in a way that they also enjoy, and no longer being so isolative at times. But we sometimes miss out on these residual symptoms that are persistent, and yet they seem to affect mood somewhat, but the mood is better. But as you've mentioned, Michael, the presence of these residual symptoms increases the risk of recurrence, and maybe is an obstacle to a full functional recovery. We're going to focus on three, and the top three residual symptoms are sleep disturbances, fatigue, and cognitive impairment. We'll take them each in turn. Paul, can you lead us in a discussion about sleep as a residual symptom?
Yeah, I'd be glad to, Les. So, as Mike, you've already told us already, sleep problems are very common in patients who are being treated for depression who are actually improving in their depressive symptoms. In depression, there are a constellation of symptoms which involve mood and pleasure and motivation, energy, cognition, feeling bad about yourself, suicidal thinking. There's all these different symptoms that we look at when patients are coming into our office, and we're analyzing to see how well they're doing with their MDD. And when we're doing that, we have to ask about sleep, because take a look at this. From the three studies presented, the Nuremberg study of 1999, sleep disturbances occurred in 44% in patients that had residual symptoms that were being treated for their depression. 44% still had some sleep disturbance. In 2010, Nuremberg came out with data suggesting sleep onset insomnia, trouble getting to sleep, was around 30%. Middle of the night insomnia, about 50%. Early morning insomnia, where you wake up really early and you can't get back to sleep again, 16% or so. Hypersomnia, which is just sleeping way too much, 24%. And Conradi in 2011 showing sleep problems of 44%. So clearly this residual is a major problem because of several things. One of them is that we've already talked about the fact that residual symptoms increase the risk of relapse, recurrence, worsening of depressive episode. And in fact, in people that are complete remitters, if their insomnia persists, they're much more likely to actually relapse into a full-blown major depressive disorder. So this is some of the information that we have about sleep and the critical nature of asking about sleep every time a patient comes in when we are following up with them on their major depressive disorder. In my experience, what I like to do with these patients is understand about their sleep really early on and potentially co-manage their insomnia at the same time that I'm managing their depression. It's not unusual for me to prescribe an antidepressant and along with that, an insomnia medication, just so that they can improve with their insomnia symptoms. And there's actually even studies that show that when you do that, when you treat insomnia at the same time that you treat major depressive disorder, the relapse and response rates are much better.
So what you're saying is addressing the mood alone is not good enough, and we have to address all these symptoms that sometimes fly under the radar when we're, happy that mood is improved, but we still need to take care of the sleep. Natalie, what medications were you taking for depression, and did they improve or worsen your sleep?
Sure. The SSRIs I was prescribed that I didn't find very effective did worsen my insomnia. So I was prescribed an atypical antidepressant, or SARI, to help with sleep while I was on those SSRIs. When I recently tried the tetracyclic antidepressant, it was very sedating and did help with my insomnia.
So even the treatment itself may interfere with the, being able to sleep better. So that's going to be tricky. What impact do these sleep disturbances have on your functioning and quality of life?
A huge, huge impact. Just the overwhelming feeling of fatigue exacerbates a lot of the negative thinking that's part of my depression, and also exacerbates brain fog. And I can tell that it impacts my quality of work.
What specifically would you want from a medication that would make you happy about your sleep and how it would address your sleep?
Yeah, I think for me, it'd be something that has a light touch. So it's not so sedating that I can't do my job, and doesn't have that hangover feel the next morning. So for example, part of my job is I'm on call overnight for both animal medical emergencies and building facility emergencies. And so I can't have a sleep aid that totally knocks me out or is, too psychedelic. But I also then need to be able to get up in the morning and be pretty functional right away. So that hangover feeling or taking a while to wake up is also really challenging. So I think a light touch that helps you fall asleep, but isn't, doesn't have a many hour deep effect.
Well, thank you for that. It sounds like having problems sleeping leads to feeling tired the next day. Addressing the sleep with a hypnotic can also make you tired the next day. The depression itself can lead to fatigue. Michael, can you lead us in a discussion about fatigue as a residual symptom?
Well, tiredness, low energy, fatigue, anergia are almost universal symptoms in people who are depressed. After depressed mood, these synonyms are present in about 80% of people presenting for treatment of depression. I hardly ever see someone who's not suffering from some sort of low energy, low drive, etc., as part of their depressive syndrome. You want to make sure that the characteristic nature of the fatigue is the same as the fatigue the person reported when they presented for treatment. You want to make sure it's not a new side effect of the medication. And so talking about the quality of the energy disturbance is important. But even when people respond to antidepressants in a good, strong way, there's maybe between a quarter and a third chance that they will have some persistent fatigue as one of their side effects. Obviously you want to make sure that this fatigue is not from poorly treated insomnia, because not sleeping well at night is one cause of fatigue. You also want to make sure that it's not a daytime residual feature of hypersomnia, because people who are oversleeping will have daytime sleepiness as well. And so additionally, I think you want to make sure that this is not a newly emergent side effect that's a consequence of the treatment. So you really do have to put your physician thinking cap, clinician thinking cap on in order to try to come up with the best plan. for managing this, and to pick a either changing antidepressants or thinking about an adjunctive treatment strategy that can address this. And, obviously, if it's tied to the sleep disturbance, proper intervention might address two of the important residual features at the same time.
Well, it sounds like it can be kind of confusing. Is this iatrogenic? Did we cause this fatigue with the medication that we're prescribing? Or is it part of the illness? Is it part of the residual symptoms of the illness that has been inadequately treated? Is it because sleep hasn't been restorative? And is that sleep part of the depression, or is sleep is part of a potential side effect? So we have to sort these things out. Natalie, your experience with this, what medications were you taking for depression either improved or worsened, specifically fatigue?
Yeah, I'll preface this by saying I, in general, have a pretty bad memory or recollection for comparing how I felt in the past to the present. I always find those scales very challenging to do. And my job is really stressful. So it's sometimes hard for me to differentiate like what the cause of my fatigue is. Is it because I worked a very stressful long day? Is it the depression? Is it the medication? But some medications, definitely did have an effect on my sleep and my fatigue. So to try to reduce any side effects, I would always take my medications at night.
Yeah, so some medicines are sedating, and it makes sense to take it at night. And the hope is that it doesn't cause some residual sedation the next morning and the next day. But what impact did fatigue have on your functioning quality of life? You mentioned it was kind of challenging.
Yeah, I think overall it really just impacts my resiliency to handle each day. It exacerbates a lot of the negative rumination that's part of my depression, specifically feeling like I'm not doing enough because I'm tired, or accomplishing enough, or exercising enough, or kind of overwhelmed about everything on my plate. And then because I'm really tired, it also impacts my ability to socialize. So I have definitely seen it kind of exacerbate my social isolation.
Well, it sounds like you want a medication that is free of fatigue. And, I think that would be fairly obvious. Everyone would want that. What else about the medication? Addressing fatigue would have other consequences, right? In terms of helping you be more alert and function more at work. And as you mentioned, being able to be on top of things, right?
Yeah. So I think balance would be really important from a medication to address fatigue. So less fatigue, but not so hopped up that it exacerbates anxiety or you overdo it and then are truly fatigued. So I think it's, all about the balance.
It sounds like this is going to be a pretty challenging issue for providers in thinking about what can we prescribe, what can we also additionally do to make things better, but don't want to make things worse. And it's true, you don't want to, have activation that would impair someone's functioning as well. And so this is pretty tricky, and this all comes down also to concentration and being able to pay attention to things. Paul, can you lead us in a discussion about concentration as a residual symptom?
Yeah, absolutely. First and foremost, let's set the stage, which is that depression is an all-consuming brain issue. The brain isn't working well in many areas. And what does the brain actually do but think, concentrate, make decisions, remember, recall? All those things get affected when patients have MDD. And in fact, even when we treat them for their MDD and they say, I'm no longer sad, I have good motivation, I'm enjoying things, my appetite is no longer affected, heck, maybe I'm even sleeping okay, but I'm still not concentrating well. I'm still not thinking that well. I can find myself sometimes fiddling around trying to find words. I do a lot of the psychiatry for a local college in our area, Ursinus College, like we mentioned earlier. And a lot of the students will come and tell me when I'm treating them for depression, even though they're a lot better with their depression, they will say things like, my grades are kind of suffering still, and they're not really catching up to me. And we see that in a Nuremberg study of 1999, they said concentration problems occurred as a residual in 22%. In his study of 2010, concentration and decision-making problems, 20.9%, and Conradi in 2011, cognitive problems up to 44%. So clearly this is a problem. And when these residual symptoms occur, a patient comes back, you've been treating them with an antidepressant, they've been on the medicine a month and a half, 2 months, maybe 3 months, and they have these symptoms. Sometimes it's difficult to know what to do for them because, in fact, it is not a complete treatment if they still have residual symptoms.
Yeah, that's a good point. If we focus too much on just the mood, we may miss the concentration obstacles in terms of someone wanting to, function better at school or at work. Natalie, what medications were you taking for depression and their effects on thinking and concentrating you can tell us about?
Sure. Even though I didn't find most of the medications I've tried very effective overall for my depression, I do think they helped me, including the SSRIs. And this may be a kind of inverse of the concentration conversation, but they helped me do a little less ruminating so that I could focus more fully on the actual task at hand. So I'm very lucky that brain fog that's impacts my work is not something that's been, a big issue for me with my depression or the medication.
Was there any point where the concentration issues got in the way of your functioning, quality of life? You mentioned the ruminations.
Yeah.
Was there anything else other than the ruminations that you noted?
I think I'm lucky that I'm not impacted by kind of the brain fog piece while at work because I'm able to focus on that. In unstructured time, I do notice an impact, inability to concentrate. So that attention to detail and recall. People in my life are tired of hearing that I have decision fatigue outside of work. So I can really hold it together and be functional at work, but outside of work, just, having that kind of decision fatigue and rumination is not fun.
No, it wouldn't be. But how do your providers assess your ability to concentrate? What kind of questions did they ask you?
Oh, gosh. Wasn't prepared for that one. I take a lot of those scales every week to try to get a hold of, if you're able to focus or relax. And I'm always scoring well on the functioning at work and focusing. It's the relaxing or enjoying hobbies or being able to do that stuff that, is still challenging.
Yeah. Let me throw something out there. When I meet with patients and they happen to like to read, mm-hmm. I like to ask them how many pages can they read at one time, and do they have to reread what they just read?
That's a
good handle on that.
Yeah, that's actually interesting because one of my big kind of tells for when I'm not doing well on a medication is I cannot read at all. So I'm pretty much audiobook only in those challenging times.
Oh, okay. Well,
yeah,
that's good to know. And for our listeners, this can be pretty handy. Asking about things like reading or watching television or a movie the person that you're evaluating and treating, can they sit through an entire movie? Can they sit through a TV show for 30 minutes? And what kind of TV shows do they are able to watch? Is it, game show or a story? Can they follow the plot? All these things can help us figure this out. In terms of the medicines, so it didn't really affect your concentration in a negative way. So that's good. You've heard from others that there's something called brain fog. So what do you understand about that?
I think probably how I feel in unstructured time when I'm in a bad place is what I would imagine other people would feel at work, like not being able to focus, feeling fuzzy. And I feel fortunate that that's not my experience at work.
Yeah. So we talked about overall, let's bring this to a close here. We have about 6 minutes to talk about the points that we've raised today about sleep, fatigue, concentration. These are not symptoms related, they're not mood like depressed mood. They're not about enjoying something or not enjoying something. They're about other symptoms that we don't always address. And if they remain present, we can have a problem in terms of a full recovery. There's something that's been studied about patients who fulfill the definition of remission, and yet they don't feel that they're in remission. Anyone want to talk about that? So, Michael, how common is that?
It happens enough that it needs to be on your radar screen, and you need to ask about it. I think that obviously you can't fully recover, and you can't fully get back to your best self if you've got this kind of lingering impairment.
Yeah, and the converse also has been observed. People feel that they have recovered, and yet they score, not low on the PHQ-9, and yet they feel that they're recovered and that they can function well. So I think it behooves us to ask about how well do people go about their business at work, at home, and socially. How can we measure that? Do we have a scale about that?
Well, I think the PHQ-9 does fine on the symptom side, but as we all know, it doesn't assess anything about your current functional status. Our DSM used to have an integrated tool called the GAF, and people scoring 80 or 90 were judged to be kind of back to their best self. I simply ask, how close to your best self are you, and what's still getting in the way?
Yeah, asking people is often the simplest thing to do, right, Paul?
Yeah, and referring to even college students, grades, that's a significant impact there. Also, what they're doing and what their hobbies are. Are they enjoying their hobbies? Are they able to participate? How are they doing on their video games if they're young adults? So asking and probing and trying to understand a little bit beyond the PHQ-9, I think, is a very important way of trying to understand cognitive abilities, fatigue, and also sleep. But the sleep part is, by the way, very, very easy to ask. When do you go to bed? How long does it take for you to fall asleep? Do you wake up in the middle of the night? How long does it take for you to fall back to sleep again? Do you wake up too early? And how's your energy level during the day? That took me only about 20 seconds to question. So they can be very important ways of gathering the information that you want to understand if a patient is in remission with residual symptoms.
Yeah, very handy to do that, and it doesn't take much time at all. The 10th question on the PHQ-9 always, irked me because it should be called the PHQ-10. But the 10th question is about the impact on functioning. Do these symptoms above that are endorsed impact a person's ability to do things they want to do? But that's not good enough, I don't think, in terms of just accepting that. I would want to ask my patients, well, what exactly are the symptoms preventing you from doing? And you get the benefit of knowing more about your patient, what they like to do, their interests, their hobbies, and it really reinforces the therapeutic alliance when you show an interest in someone's life. So I find that very valuable to do. So PHQ-9 actually is, for me, a gateway to find out more about my patient and opens up the conversation. So I'm happy about that. Any tips, additional tips from you, Paul, or you, Michael, about how to ask, what to look for?
One thing that I would say is take your time when patients come in with MDD. Make sure that you give plenty of time to have them talk about their situation and have you ask about questions, and also, of course, observe. Look at their face, look at their eye contact, look at their verbiage, look at the volume of their voice. All those things can give you an impact as to whether they're fatigued, whether they're having some cognitive issues. So give them time, and also leave time for yourself for observing the patient.
Yeah, good point.
These are great tips. And, you're so glad to see your patient beginning to feel better. That's so reinforcing. And in the course of a busy day, you might be you might be so glad to see them feel better. You don't ask the follow-up questions. What's not quite back to normal yet? And what can we still do to make things better? And I think those are the differences between being improved and being well. In our patients' lives, they make a giant difference.
Well, thank you for that. Natalie, thank you for answering the questions that came up here and giving your perspective. I think they're critical to understanding what we're doing day to day in treating people with major depressive disorder. And I hope this has been helpful to our listeners. In terms of next steps, you do want to get your CME credit. And here is the URL as well as the QR code that you can point your phone to and claim your credit. And Michael and Paul, again, thank you for this great discussion. And Natalie, again, thank you for the discussion, providing us with your perspective. Really do appreciate that. And I want to thank everyone who's listening and thanking you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.